And I'll invite the panelists for the next case, Dr. Swapnil, Dr. Rakhi, I think she just called that she's not able to make it, Dr. Rohit Mehtani, and Dr. Abhideep Chaudhary. So in the next 20 minutes, I'll take you through a case and special considerations in management of MASLD-related decompensated cirrhosis. So this is real life, and this is what we've been talking of since yesterday, trying to prevent decompensation, but patients do get decompensated, and how do we deal with them, and what are the different issues pertaining to MASLD. So I'll start with a voting question. Which one of the following is not a special consideration in managing MASLD-related decompensated liver disease? Which is not a special consideration. So variceal bleed, renal dysfunction, portal vein thrombosis, HCC, or sarcopenic obesity. This is the audience poll, please. Can you start the... Have you started the poll? So which is not a special consideration? Variceal bleed, renal dysfunction, PVT, HCC, sarcopenic obesity. Okay, so can I see the result again? Can you show the result? Okay. Okay, so I think, yeah, very few have actually got it right. So it's variceal bleed. So you do have renal dysfunction. There is a higher incidence of portal vein thrombosis in patients with MASLD. Of course, we know that there is higher HCC, and sarcopenic obesity also occurs in patients with. So the answer is actually variceal bleed. All of them are special considerations in patients with MASLD-related decompensation. So this is a 64-year-old female, known case of liver cirrhosis, has diabetes and hypertension for the last 10 years, hypothyroid. Presently came with, she felt that her eyes were more yellow, had some decreased urine output, and some swelling in the feet. Her exam was essentially normal. She had, on examination, not much ascites. She did have yellow eyes and bilateral minimal pleural effusion. She had a weight of 94 kilos, height of 155 centimeter, BMI of 39. I know Dr. Sanyal told us in the morning that BMI is a horrible thing to see, but then this is what we have. So she's a known cirrhotic, and presently came with a creatinine of 2.3, a bilirubin of 3.5, and although she noticed yellow eyes recently, but when we went through her records, she's been having a bilirubin of around 2.5 for the last 6 months, so just was marginally raised over her previous bilirubin. So her MELD sodium score on calculation was 27, a CTP of 10, child C, and she had a performance status score of about 70. But if you look at the bilirubin, it's just marginally more than 3. Her INR is 1.67. Later it became 1.77. So it adds up to 10, but on a good day, it could be 9 also. It could be 8 also. So it maybe late B or early child C cirrhosis. We did an endoscopy. She had a grade 3 varices with reticular signs, and we banded her. You can see the MRI, which shows some minimal perihepatic fluid, not really gross ascites. But she does have history of LVP once a couple of months ago. And later on, we also did a psoas muscle thickness at L3, which was 11.7 mm, and I'll talk of that a little later. So the final diagnosis is MASLD-related decompensated liver disease, grade 3 varices, banding done, ascites, LVP 2 months ago. Now she doesn't have ascites, surprisingly, because she hasn't been on diuretics because of renal dysfunction. Jaundice, coagulopathy, she has gallstones, probably acute on chronic kidney disease. Baseline creatinine has been around 1.5, 1.6. Had a UTI right now when she was admitted. And so comorbidities, diabetes, hypertension, hypothyroid, morbid obesity, and some axonal neuropathy. So this question was for Rakhi, who is the kidney expert in liver disease, but I'll ask maybe Swapnil, if you could tell us how to evaluate renal dysfunction in patients with, or in this patient. You know, she has a baseline creatinine of 1.6. So what do you think is the reason for a high creatinine, and why has it gone up? So what is the acute component, or what are the causes?
So I think this is probably HRS CKD, and as you mentioned that she had a baseline creatinine of 1.6. There is some acute component which could be maybe because of previous use of diuretics or any other reason. So I would say it like an HRS CKD with some acute component.
Okay, and what about the chronic? Why do you think she has a creatinine of 1.6? How do you evaluate such patients?
So, I mean, she has a complete metabolic phenotype with diabetes and with a proteinuria of 1.5 gram. So, could be related to diabetic nephropathy.
So, Rohit, any thoughts? Do you think MASLD itself can cause CKD without, you know, let's say she didn't have diabetes?
MASLD-associated CKD, that would entail presence of either ascites, long-standing, which has progressed to, as Dr. Swapnil mentioned, HRS, going on to develop CKD. For this case, I would also like to get an ultrasound of the kidneys to see whether there is any change in the CM differentiation or the kidney size. Then proteinuria is already there. Second, in diabetes, we should also do a fundus examination to see whether there is diabetic retinopathy or not. In the presence of diabetic retinopathy, the renal dysfunction chronic component would most likely be due to diabetes.
Yeah, so yeah, this is how you usually evaluate renal evaluation in patients with end-stage liver disease. And like you said, you know, you need ultrasound, maybe some other markers, and probably very rarely we do kidney biopsies in such patients. So what about managing diabetes in a decompensated chronic liver disease patient? She's diabetic for 10 years. When she came to us, HbA1c was 7.8. She does have some nephropathy. She was only on, she's been taking metformin from her physician. So how do you manage diabetes in this patient with decompensation? Rohit?
The drug of choice would be insulin in this case. So once there is decompensated cirrhosis along with nephropathy, there is an increased incidence of hypoglycemia with the use of oral hypoglycemic agents.
Right.
So the best
and
drug would be
what about SGLT2 inhibitors? You think we can use them? Diabetes, MASLD, nephropathy?
So we need to carefully consider the risk of infections and dehydration with, as she also had ascites, there would be some amount of diuretics which would be used. Along with diuretics, we discussed in the morning that there is increased risk of dehydration and developing AKI. So that should be kept in mind.
Yeah, so I think that's what our endocrinologist also did, put her on insulin. Any thoughts, Dr. Sehgal? You put this patient on insulin?
Yeah, thanks. I think that's a very important point, and I've always seen that once you decompensate, then the drug of choice really would be insulin, in my opinion. And I think you're right. Only thing is that I've realized that a very strict control of HbA1c probably is not very desirable. Actually, like we don't have very strict that make it 6 or a little high is also okay. But I think my personal feeling is that insulin would be drug of choice.
Right. So coming back to the patient, now her BMI is 39. She has, I don't know if she has sarcopenic obesity or not. The psoas muscle thickness was 11.7 mm, and her performance status is 70. That means she can carry out, her own daily activities, self-care, but not really active work. And so, Swapnil, we've been talking of, nutrition and exercise and diet since yesterday. What kind of diet do you give to a decompensated, obese, MASLD patient?
So I think the first part, definitely this patient has got sarcopenic obesity, and it's defined by sarcopenia, either by you can define by L3-SMI, which we don't have it here. But the psoas muscle thickness to height ratio is, the cutoffs are well within the sarcopenia range, and her BMI is definitely more than 35, even if you adjust for the dry weight. So there are two components of sarcopenia and obesity, and it's sarcopenic obesity. So patients with decompensated cirrhosis, so depending upon the BMI, they should have a, if the BMI is say less than 35, so they should have 25 to 35 kilocalories per day of calorie intake, as compared to if the BMI is more than 35, then it should be 20 to 25 kilocalories per day. And the diet has to be proteins, usually 1.2 to 1.5 grams per kg in patients who are not critically ill. And it should have late evening snacks and early morning breakfast with minimum gaps in between two meals of around 4 hours. Exercise should be a combination of aerobic and resistance exercise, as we discussed a day before, and flexibility and stretching depending upon
so obviously this patient really can't do any aerobic exercise.
So,
and
depending
so
upon what the patient has, I think it
yeah.
has to be individualized, definitely.
Yeah. Any thoughts, Rohit, on, because you want this patient to lose weight, and but not, you need to give not muscle mass.
So in the initial phases, when she has just recovered from an acute illness, I would not focus too much on restricting the calories. We need her to, her liver functions to stabilize first. So a high, like Dr. Swapnil mentioned, 25 to 30 kilocalories per kg per day, along with a high protein diet. And then as the she remains decompensation free, then at that point of time we can slowly start restricting the calories.
Okay, so she's 94 kilos, decompensated chronic liver disease, MELD sodium of 26, child C. Now, since yesterday we've been talking of weight loss strategies. Now, this is a patient actually in whom we might want some weight loss for two reasons. One is maybe improvement in liver function, and the second, if she needs a transplant, it's going to be very difficult to transplant her. We'll discuss that in a bit. So, any weight loss strategies, Dr. Rohit, for this patient?
So, lifestyle, including diet and exercise, forms a backbone.
No, so I want an answer for this patient. I mean, I don't think she can exercise here.
So, exercise, basic exercise which we can advise them is just continue the moderate, like aerobic exercise, like go for a routine walk at the most. And then apart from that, in exercises, it would be difficult for her to do a resistance exercises. Then in diet, we can start restricting the calories by 400 to 500 kilocalories per kg.
Neeraj, can I ask a question? Here, Manav, this side.
Yeah.
So, you really want to restrict diet in this patient?
No, I'm not. I'm asking.
Yeah. I beg to differ. That's so the message.
You might want to lose weight, but we don't want to definitely.
There is no way you can have a decompensated patient lose weight without losing muscle mass.
I agree. So yeah. So
our effort should be rather optimize the patient for transplant without looking at calorie restriction. You may want to increase exercise, I completely agree, but I will not be in favor, personally I am not in favor of asking any restrictive diet for this patient.
Yeah, so actually, I've given 4 choices here and I think the answer is none of them. Yeah, I totally agree with that. So,
reiterate that none of them.
Yeah, but, so yeah, lifestyle, obviously, like you said, you probably won't want any significant weight loss or muscle loss anyway in this patient. Most drugs, in fact, all drugs are contraindicated. Bariatric surgery procedures, again, some data in cirrhotic patients compensated, but not really in decompensated patients. We know that semaglutide is again contraindicated. Bariatric surgery, again, contraindicated in patients with significant portal hypertension. Now, we know that there is significant cardiac morbidity in patients with MASLD liver cirrhosis. Now, this patient didn't have any cardiac comorbidities, although she did have hypertension. But this is a question I'm going to put to vote for the audience. Supposing this patient had cardiac disease, double vessel disease, needs an intervention, revascularization. She's had a recent band. Her INR is 1.7, her platelets are 115. So how do you manage coronary artery disease in such a patient? This is a voting question. PTCA, CABG, would you use a drug-eluting balloon dilatation or a combined liver transplant plus CABG? Okay, so most people say PTCA. Yes, I guess PTCA can be done. Her coagulation parameters are not too bad. And so that is, I think CABG is probably the only one which you can not do for sure. Drug-eluting balloon dilatation could also be done. And we have done about, I think, 8 cases of combined coronary artery bypass graft with liver transplantation, but that's not again, a very standard routine procedure. So coming to further management of this patient, she is child C, MELD 26, MASLD, there's hardly anything reversible. EGFR is 28 on discharge. Minimal ascites, no HE. How do we proceed for management? Dr. Abhideep. So would you continue medical management? I know you're a surgeon, so you would probably go for the liver transplant.
Yeah.
And I'll ask you how, but do we really have any scope for medical management in this patient?
I mean, in this kind of situation, now I would like to go for liver transplant in this patient. And with obviously, there are some preparations that would be required in taking up this patient for transplant. And that would answer your previous question as well. So what we have been doing in our center with BMIs more than 30 is, yes, exercise in these performance status patients are difficult, but we still have options. These patients, whenever we see, they have proximal muscle weakness more than distal. So what we need to work on is a pulmonary physiotherapy as well as the proximal muscle physiotherapy. That is something which actually helps a lot in these patients. The second thing is why I say transplant is adequate decompensation has happened, and this is not going to recover with medical management, even if we try and achieve weight loss. And if we wait long and there is enough data to show on the basis of waitlist mortality, these patients die more on waitlist compared to non-MASLD patients. Third thing is that if we wait, this patient would ultimately require simultaneous liver kidney rather than liver alone. So looking at all these scenarios, I think we should proceed with transplant.
Yeah, I think at present she can probably get away with the liver alone because it's a short, although the EGFR is less than 30, but it's a short period and probably there is some reversibility. Now the problem which we face every day, and I'm sure you do too, is how, you work in Delhi, hardly any DDLTs. How do you do a living donor transplant for this patient? Where do you get a donor who can give enough liver to have a GRWR decent, maybe at least a 30% remnant? And I think if you do find such a person with such a big liver, they're probably going to be fatty themselves. So how do you do a LDLT in this patient?
First and foremost thing, we have to forget now 0.8 of GRWR.
So I didn't say 0.8, I said a decent, maybe 0.7 also. It's not going to be easy.
So the thing which we need to understand in these patients is the fat metabolic requirement is very minimal. Actually, going by BMI, rather than that, we should look at the body fat index and then decide how much liver is required. So problems with these patients are, as you have rightly pointed out earlier, they have more portal vein thrombus. That is something which is more difficult to manage than the GRWR in this situation, because the requirement of liver is not same as a healthy, a fit person with bigger muscle mass with a high BMI compared to these kind of patients which has more fat. Even if you give them a 0.6 or now a recent publication, less than 0.6 also, these patients can do well with that. Now, important thing is the minimum liver mass. It can be 600, 650, 700. Various studies have shown various numbers, but a minimum mass with right amount of portal flow going to these livers. which can be modified using portal inflow modulation, and you can use these levers. So earlier, we used to talk a lot about dual lobe transplants, which has not gone in support to various centers because a lot of centers have now shown a lesser GRWR can be adequate for these patients.
Yeah, so we also do portal flow, inflow modulation. We've published on that too. Although we do dual lobes as well, but I think we're doing that less. Obviously, I think there is a higher surgical risk, higher post-operative morbidity and mortality. Dr. Sehgal, do you think these patients, after transplant, they do worse as compared to other etiologies? MASLD. So compared to a HBV or the alcohol, do you think long-term outcome is worse?
Say, if you take this patient, then of course this is a sick patient. But in general, if you ask me that MASLD as a blanket, do they have a worse outcome compared to non-MASLD? I don't think that is being reflected in our practice so much. But people, we have seen that those who are sick, like this lady is sick, and her EGF is very low. She has got so many other problems. So her outcome will be a little lower than what I would expect in other patients. But so in general, as a blanket, I would not say that
there is some data to suggest. And
but I know, there's some data which we say that.
MASLD patients do worse long-term as compared to patients with other etiologies.
One other thing, Neeraj, we were doing, remember we did once in our study a bioelectric independence, BIA analysis.
Yeah.
So that is also a good tool to know what is like Abhidip said, fat content. So it just gives a good idea of the fat and muscle mass, and the sarcopenic obesity is very well delineated. So these patients, when you follow post-transplant, which you rightly said, they have a significant 70 to 80% have sarcopenic obesity post-transplant.
Yeah,
if you do the BIA.
78%. That's
what we published. Yeah. Yeah.
So to summarize, MASLD patients do have, MASLD decompensated patients do have a lot of special considerations which you need to watch out for. They have comorbidities, obesity, diabetes, cardiovascular disease, CKD, and of course, nutrition is a challenge. Weight loss, if at all you want, is a challenge, maybe even to get them fit for a transplant. And doing a transplant in such patients is challenge in finding a suitable donor, the surgical risks and the post-operative risks. Thank you.